Welcome to Topic 3, Part 2. In this screencast, we're going to talk about disorders of immunity. Now you can see from our learning objectives, we're going to talk about both hypersensitivities and autoimmunities, which are on the next page. Okay, so, and these are both disorders of immunity. So we have two ends of the spectrum. We have hypersensitivity, where we have excessive or inappropriate activation of the immune response. And here, this is when we have a reaction against an antigen that would otherwise be harmless, and this causes damage to the body. This includes allergies, which are against environmental antigens, alloimmunities, which are against antigens of the same species, such as we would see with an incompatible blood transfusion reaction or transplant rejection. And then autoimmune disorders is when the body attacks self-antigens displayed on self cells. And then on the other end of the spectrum, we have immunodeficiencies, and this is when the immune system is inefficient or ineffective at fighting disease. Now, all the hypersensitivity disorders, allergies, alloimmunities, and autoimmunities involve one of the four types of hypersensitivity reactions that we're going to talk about. Type 1 is an immediate hypersensitivity reaction, which involves IgE antibodies. Type 1 only includes allergies. Type 2 is antibody-mediated, and this is when we have IgG or IgM antibodies that are against cell surface or extracellular matrix. And this produces a response, and this can occur with allergies or alloimmunity or autoimmunity. Type 3 is an immune complex mediated mechanism of action, and this is where we get antigen antibody complexes and the antibodies are IgM or IgG, and they get deposited in the circulation. This can occur in some types of allergies and in autoimmunities. And then the above three are all antibody mediated and occur fairly quickly. Type 4 is the only one that is cell mediated, so this is mediated by T cells. So the delayed type, we have helper T cells that are involved that activate other cells that produce a response, or cytotoxic T cells that directly kill cells. This occurs in some autoimmunities as well as in reactions such as a poison ivy reaction. Okay, so let's look at the mechanisms of how these things work. So type 1 is an immediate reaction against environmental antigens or allergens. So remember, an antigen would, an environmental antigen should otherwise not be harmful to the body, but in persons with allergies, this can produce a response. This could be due to drugs or insect venoms, various foods. So here we have, on the first exposure to an allergen, we see the helper T cell is going to get stimulated, and this is going to cause B cells. It's going to activate B cells, which are going to differentiate into plasma cells, which are going to secrete IgG antibodies. These IgG antibodies then bind to mast cells or basophils, and they become sensitized. Then on any subsequent exposure, allergen binding to those antigens on the sensitized mast cells are going to cause those mast cells to degranulate and release chemical mediators such as histamine. It's also going to cause those mast cells to produce prostaglandins and leukotrienes, and this is going to result in our responses. The signs and symptoms of a type 1 hypersensitivity reaction are going to depend on the location of the sensitized mast cells. In atopic reaction, these are localized. So we have localized mast cells that have been exposed to the antigen in specific areas. So we could see this like if it would be in the airways, then we could get asthma, in the gut, food allergies, hives, if mast cells in the dermis were exposed, and so forth. Anaphylaxis is a systemic response to those mediators that are released into the blood. So these involve basophils rather than mast cells. Basophils are the precursor to mast cells that are found in the blood. So this can occur in response to insect venom, insect sting, food allergies due to absorption of that antigen into the bloodstream from the GI tract. The level of severity of anaphylaxis is going to depend on the level of sensitization. Okay, how many basophils have been sensitized? So a little more on anaphylaxis. So it's a systemic or body-wide response to the inflammatory mediators. So let's think about it. What could happen if the arterioles throughout the body vasodilate? And what will happen when the bronchioles constrict? So let's think about that. If the arterioles throughout the body dilate, this is going to cause a decrease in peripheral resistance, and this is going to dramatically decrease the blood pressure. And this can lead to anaphylactic shock. When the bronchioles constrict, this is going to make it harder to get air in, and this is going to contribute to an emergency situation. Some other signs and symptoms. You could see, like I already mentioned, the low blood pressure. You see some hives and itchingness, flushing, the shortness of breath, the wheezing due to the bronchoconstriction, coughing. We can get some excess mucus with the histamine exposure as well. And then because we're not getting enough blood or oxygen to the brain, we could see central nervous system signs as well. Treatment for anaphylaxis is going to require a first aid response. The first step is to administer an epinephrine pen if it's available. Now, epinephrine is going to reverse many of those effects of anaphylactic shock. So epinephrine is going to cause an increase in heart rate and an increase in cardiac contractility, and that's going to help to increase cardiac output, and that would help to raise blood pressure. Epinephrine is also going to cause constriction of arterioles, and that will help to raise the peripheral resistance and raise the blood pressure. And then finally, epinephrine is also going to cause bronchodilation, which should help reverse the bronchoconstriction effects of histamine. Other things that might be given, glucocorticoids to reduce inflammation. So remember, the capillaries are also going to be kind of leaky in response to that inflammatory reaction, and glucocorticoids are kind of going to help to reduce that inflammation. Antihistamines to help combat the effects of histamine, oxygen, and other drugs to stabilize the blood pressure. Okay, let's talk about a type 2 hypersensitivity. These are also called tissue specific. They involve either endogenous antigens or exogenous antigens, such as drug metabolites that get attached to cell surfaces or extracellular matrix. Here it involves IgG or IgM antibodies that bind to the target antigen and produce the response through one of three mechanisms. The first one is complement and antibody-mediated cell destruction. An example of this is incompatible blood transfusion. So these antigens on this red blood cell are incompatible, and this is going to cause antibody binding to those antigens, which will then activate complement, and then we get complement-mediated phagocytosis. Number two, we have antigens expressed on the cell surface or extracellular matrix, and we get antibody binding to that, and this activates complement and produces tissue inflammation and injury. We can also get abnormal receptor function. So we have antibodies that combine to a receptor, producing an unwanted response. An example is in Graves' disease, in which we have antibodies that look just like the TSH hormone, which binds to thyroid cells and produces causes that cell to produce thyroid hormone. And then finally, we can have receptor blockade. So here we have antibodies that bind to a receptor and prevent that receptor from binding to its ligand. As in the case of myasthenia gravis, these antibodies can both block these neuromuscular junction acetylcholine receptors and also cause destruction of them. Other examples also include Rh disease and autoimmune hemolytic anemia. In type 3 hypersensitivity reactions, we have the formation of antigen antibody immune complexes, and this is with either IgM or IgG antibodies. The antigens may be exogenous, such as viral proteins, or they could be endogenous, such as DNA, like we would see with lupus. Here, these immune complexes get deposited into the blood vessels, and then they attract inflammatory cells, leading to tissue inflammation and injury. Now, these reactions can be systemic or localized. Vasculitis is a localized inflammatory response in blood vessels, and serum sickness is the term used to describe this systemic response, in which we get complexes deposited in blood vessels throughout the body, such as we would see with lupus. A type 4 hypersensitivity. This is the only one that is cell-mediated rather than antibody-mediated, and this is through sensitized T cells. And T cells can exert their effects through one of two mechanisms. The first mechanism is directly. So here we have our helper T cell that gets activated, that then activates our cytotoxic T cell that directly attacks the target cell. This can occur maybe in a viral reaction or with acute graft rejection. Another example is the delayed type hypersensitivity reaction, and here we have helper T cells that release cytokines that then activate other immune cells to cause phagocytosis. Now, this response is delayed about 24 to 72 hours due to the time to synthesize those proteins. Examples of this include the response you see with a positive TB test, or allergic contact dermatitis, such as with or like poison ivy, and hypersensitivity pneumonitis. As with all hypersensitivity reactions, these reactions require a prior sensitization with the antigen. So in other words, you've been exposed to the antigen the first time, and that causes the production of these activated cells in these memory cells, which then is going to produce a response on subsequent exposure to that same antigen. Okay, so now we talked about the 4 different mechanisms, and now of how those reactions occur. Now we're going to talk about those 3 different categories of hypersensitivity. So allergies is an immune system that reacts against environmental antigens that would otherwise be harmless, such as pollen or dust or pet dander or foodstuff. Alloimmunity is when the immune system reacts with antigens on the tissue cells of other genetically dissimilar members of the same species, such as could occur with an incompatible blood transfusion. In hemolytic disease of the newborn, which can occur with Rh incompatibility, or with transplant rejection. I want to talk about transplant rejection. There are 3 types. Hyperacute is an immediate response. It occurs immediately to hours or days. And this is where we have pre-existing antibodies already. And these antibodies react with the graft and produce a type 2 hypersensitivity reaction in the blood vessels of that graft. An acute transplant reaction occurs within the first few days to weeks, or it could occur suddenly months or years after you stop taking an immunosuppressant drug. Here, exposure of the transplant causes activation of the immune system, which generates T cells and antibodies against the graft, which leads to both cell-mediated via T cells and humoral-mediated via antibodies tissue damage. And then chronic rejection, which takes months to years. This is where we see gradual changes in arterial blood vessels thought to be due to T cell generated cytokines, which leads ultimately to ischemic changes and graft failure. So what are some things that can help prevent rejection? Well, having a good HLA match in living donors, neonates and infants because their immune systems are not as developed, and then immunosuppressant drugs. So you can take these drugs to help prevent rejection. However, there are side effects. You're more likely to get uncontrollable infections and cancers on long-term immunosuppressant therapy. An interesting study I read was that one spouse donating to another seems to have better success rate than a donation of a similar HLA match of an unknown donor. This was referred to as the frying pan theory. You can see why they're in that picture. Okay, autoimmune diseases. This is where the immune system attacks self-antigens due to a loss of self-tolerance. So we get these antibodies that are formed against our own body antigens, and that produces a response that can damage our tissues. It can affect a single organ or tissue, or it can be more widespread or generalized, such as we see with lupus. There's some potential causes. There seems to be perhaps a genetic susceptibility to autoimmune diseases, a loss of immune tolerance following destruction and formation of antibodies to antigens, where antigens foreign antigens kind of look like certain self-antigens, inappropriate activation of helper T cells by superantigens. These are just some potential causes. Autoimmune diseases are mediated through type 2 and type 3 hypersensitivity reactions. Examples include Hashimoto's thyroiditis, lupus, rheumatic fever, myasthenia gravis, scleroderma, and pernicious anemia. Lupus, systemic lupus, is a chronic multi-system inflammatory disease. And here we get antigen-antibody complexes that are formed against DNA, the host's DNA. It involves multiple organ systems. In joints, it results in arthritis across multiple joints. Skin, we get characteristic butterfly rash on the face and photosensitivity. Kidneys, glomerulonephritis, that's inflammation of the glomeruli. The lungs, we get pleurisy, inflammation of the pleura. Heart, carditis, especially pericarditis, that would be inflammation of the pericardium. In blood vessels, it can cause Raynaud's phenomenon. We'll talk about that more with cardiovascular disease. Central nervous system, it can lead to mood changes and seizures. In bone marrow, depression. As with most autoimmune diseases, lupus is more common in females, with about a ratio of about 10:1 females to males. Okay, take a look at these concept checks and make sure you can answer these questions regarding hypersensitivity reactions and diseases. Okay, we have a test your knowledge question. Case, we have a 32-year-old man that presents in the allergy clinic with complaints of allergic rhinitis or hay fever. His major complaints are those of nasal itching, nasal congestion, profuse watery drainage, sneezing, and eye irritation. He has edematous nasal mucosa and red ocular conjunctiva. And he relates that this happens every fall during ragweed season. Okay, so it's got seasonal allergies. Explain the immunological mechanisms that are responsible for his symptoms and suggest possible treatments that might help relieve his symptoms. Okay, so he's probably experiencing allergic rhinitis, okay, based on those symptoms. This diagnosis fits under the category of a type 1 immediate hypersensitivity reaction, which involves IgE antibodies. Okay, so this is probably going to involve mast cells that are localized in the nasal cavity to produce some of these symptoms. Treatment is symptomatic usually, and it would include things like antihistamines, corticosteroids that can be inhaled in the nose, allergy shots, and avoidance of the allergen. Okay, let's talk about immunodeficiencies. So that's completely opposite of a hypersensitivity. With immunodeficiency, we have a partial or total loss of one or more immune system components. We can divide these into primary deficiencies, which are congenital, or you're born with it, and secondary or acquired immunodeficiencies. Primary deficiencies involve a developmental failure in the system. We can have B-cell deficiencies, antibody deficiencies, T-cell deficiencies, or combined immunodeficiency disorders, which involve deficiencies in both B and T cells. The secondary or acquired immunodeficiencies are much more common, and this involves a loss of immune response due to a specific cause, such as immunosuppressant drugs, radiation, chemotherapy, malnutrition, and so forth. With immunodeficiency, we can see the development of unusual and recurrent severe infections. The patient is predisposed to development of opportunistic infections by what would normally be harmless microorganisms, and will have an increased risk of cancer. The one such example of a primary immune deficiency syndrome is severe combined immunodeficiency syndrome. This is a genetic disease in which there is insufficient numbers of both B and T cells. This is more common in boys and girls because it's X-linked recessive. About 50% of the cases are X-linked recessive. These patients are usually affected by really severe bacterial, viral, fungal infections early in life. The babies often are going to present with an interstitial lung disease, diarrhea, lots of ear infections, and pneumonia. Untreated, babies usually don't live past 2 years. The treatment is stem cell transplant. The most famous child with this disorder is David Vetter, who was provided by NASA with the suit. So this is the original Bubble Boy. If you get a chance, there's a movie where John Travolta plays David Vetter. You'll have to check out. Okay, and then the most common acquired immunodeficiency syndrome, or at least the one we've probably heard the most about, is going to be AIDS. And this is caused by viral infection with the HIV virus. HIV depletes the body's helper T cells, resulting in a reduced immune response. So HIV binds to the helper T cells, gets taken inside the cell, the virus replicates inside those cells, new viruses get released from that cell, and then destroy more helper T cells. So over time, you gradually lose your helper T cell population. HIV is transmitted in body fluids through sexual contact, breast milk, and blood-to-blood contact. The infection involves three primary stages. The primary infection phase is when you have a huge increase in the viral replication. Initially, you get signs of systemic infection that occur 1 to 4 weeks after exposure and last about 7 to 10 days. After this, the immune system responds because now we've produced a lot of antibodies against HIV, and they appear in the blood in about 1 to 6 months, and you can test then for the presence of those antibodies to determine if you've been exposed. During the latent period, we have no signs or symptoms of illness. The viral load stays relatively constant, but the helper T cell count continues to fall. This latent period may last 8 to 10 years or much longer. With the use of drugs they have nowadays, this can last much, much longer. And then overt AIDS occurs when the helper T cell count is less than 200 cells per microliter, and or you have an AIDS-defining illness. During this time, we also have an increasing viral load. Without treatment, once you reach the overt AIDS stage, this can lead to death in about 2 to 3 years. Some of the common effects that we see with AIDS are opportunistic infections. Remember, those involve organisms that typically don't produce an infection. You only see that when the immune system is impaired. So we can see bacterial pneumonia, fungal infections, protozoa infections, herpes, HPV, are just a few examples. You're also going to see an increased incidence in cancers. Kaposi's sarcoma is one example. A cervical and anal carcinoma is another example. Non-Hodgkin lymphoma. And then finally, wasting syndrome, in which we have weight loss of at least 10% in the presence of diarrhea or chronic weakness with a fever. Okay, so be sure you check out the concept check, and then we have a couple questions for you. So AIDS is an example of a disease in which patients are immunocompromised. Which immune cells are affected in AIDS? The answer is T cells, helper T cells, which are CD4. A child of 5 months of age presents with thrush, a yeast infection of the mouth. In the last 2 months, he has had recurrent bouts of otis media. That's an ear infection. His tonsils are very small. Okay, and remember, tonsils usually contain a lot of lymphocytes. Laboratory analysis indicates a low lymphocyte count and no T lymphocytes. Further analysis indicates a genetic mutation of the T cell receptor that affects maturation of all T cells. The final diagnosis is severe combined immunodeficiency disease. A bone marrow transplant is being pursued with cells from his HLA-matched sibling. Explain why infections were not present in the first few months of the child's life. Explain what would be the impact of an absence of T cells on both humoral and cell-mediated immunity. And explain why it would not be advisable to administer a live vaccine to this child. Okay, so the first question. Let's flip back here. Explain why infections were not present in the first few months of a child's life. And this is because the newborn baby is provided some protection from the mother's antibodies. But these do degrade over time, and they're going to decrease significantly in the first few months of life. Number 2, what would be the impact of an absence of T cells on both humoral and cell-mediated immunity? The absence of T cells is going to hurt both, okay, because helper T cells activate both arms of the immune response, both humoral, involving B cells, and cellular, involving T cells. And then, why would it not be advisable to administer a live vaccine? It wouldn't be advisable because they can't mount an effective immune response. Okay, next question. A 20-year-old woman has been diagnosed with IgA deficiency. She's been plagued with frequent bouts of bronchitis and sinus infection. Why are these types of infections particularly prominent in persons with IgA deficiency? So here's where you have to remember that IgAs are the predominant antibody found in mucus secretions. Okay. Such as saliva, nasal, and respiratory secretion. Persons with impaired cellular immunity may not respond to the tuberculin test. Explain. I don't think I have. And that's going to be true, okay, because if they have impaired cellular immunity, that involves T cells. And that's T cells are involved in the type 4 hypersensitivity reaction. So without a good response, they would have a negative skin test for TB. But that doesn't necessarily mean that they haven't been exposed to TB, but rather if they don't have an appropriate T cell response, if that makes sense. Okay, an infant is born to a 29-year-old HIV positive woman. Is the initial antibody test is positive? Does this mean the infant is infected? Let's think about that for a second. Okay, the answer is going to be no. The diagnosis of HIV infection in children born to HIV-infected mothers is complicated because that baby has received maternal HIV antibodies that cross the placenta to the fetus. So infants born to those mothers can be positive for the test up to 18 months of age, even if they're not infected. So we can't accurately determine if the baby is infected or not at this point. And that's it. We'll see you for Unit 2. We're going to start with Topic 4 involving disorders of blood cells.